So we've talked a lot about olaparib moving it to frontline in the BRCA patients. We've talked a little bit about niraparib and how at this meeting it shows that in the patient that weighs less than 170 pounds and who in the beginning's platelet count is less than 150, you really need to start at the 200 dose rather than 300 dose. We've not talked about rucaparib. Rucaparib is, on April 6, 2018, was the third PARP inhibitor to get approved in maintenance in the second line PR or CR cohort. Tell us about Ariel 3.
So Ariel 3 had a very similar design, such as the NOVA trial, where all comers were enrolled.
NOVA being niraparib.
NOVA being niraparib, correct. And really remarkably, and we've talked about this, is that the results of the Ariel 3 really mirror the NOVA trial with niraparib around that non-BRCA group. And I think Mike's already alluded to it. When you're looking at the HRD population, that pulls out a subset of patients who are going to be more sensitive to the PARP inhibitor. And then that BRCA negative, HRD negative setting, there was some benefit in Ariel 3, but I think even a little bit less so than in NOVA. So rucaparib, yes, FDA approved for maintenance, and a very good PARP trapper. We haven't talked about PARP trapping, but that's another mechanism of how PARP inhibitors work, very similar to olaparib and niraparib.
You know, I like to put things into historical perspective. If you recall, a long time ago, 2005, we compared PLD to topotecan. And PLD in the Gordon study was better, pegylated liposomal doxorubicin. So it was easy. We had a comparative trial. Topotecan was fine when we had it, 10 Bokelhunig. Now we have Gordon PLD, and it was fine. Then in 2006, we got carboplatin gemcitabine versus carboplatin alone. It was fine. So we had a carboplatin gemcitabine option, had a what we called then platinum resistant. That was easy. And then we only had one angiogenic, bevacizumab. That was easy. Now we have three PARP. Now we have three PARP inhibitors in the same indication.
That's right.
So it was all very compartmentalized and very easy to educate. And now we have to decide PARP versus Bev, and you helped us. Now you got to decide which PARP.
Yeah.
How in the world do I decide, Professor Beer, niraparib, olaparib, or rucaparib in my patient who I decide you need a PARP and you're responding to second-line platinum-based chemotherapy, and I'm going to give which one?
Well, I think
it's not so funny. It's a common practice, and I think we all agree that observation is not a good idea.
I'm glad Mike's getting that question before I
know.
That's good. Thank you for doing that.
Well, I laugh only because it is funny in the sense that we spent years talking about IV versus IP or docetaxel versus Taxol. Those are challenging, if not boring questions. We really now have choices, and as you point out, you're sitting in front of a patient, you have to make the choice. I think for the PARPs, it is very difficult, at least for me, based upon all of those randomized phase 3 trials with hazard ratio that are so impressive and are completely consistent to argue that there's a efficacious major difference in efficacy between the three agents. So I think the choice comes down to sort of toxicity profiles, which are different, and convenience for the patient. So there are so let's just talk about that. There are class effects for PARP inhibitors, fatigue, some GI toxicities. They're usually manageable. There are class effects, you see them in all the agents. The major differences that we could point to is the thrombocytopenia issue with niraparib.
But that goes away if we start
goes
at
away with the 200.
200 is probably going to solve it, and we know we can identify the patients who have the problem with it. Yeah. So there are even ways you can finesse that. So if you have a patient who's real thin, you might think of a different PARP inhibitor, or you might use the reduced dose. Rucaparib has some interesting profile issues. So it has elevations in transaminases, which is not liver toxicity, but nevertheless it happens, and people need to be aware of that. And the similar phenomenon with creatinines, which is a pump problem. It's not a toxicity for the kidney. Dosing is interesting. I actually think niraparib is pretty convenient. As you say, once a day, and you can dose reduce very easy. Rucaparib, you have to write a new script for dose reduction. It's a little challenging. So that's where I am right now in terms of trying to make those choices. It may be made for you. So in
Yeah,
some
exactly. Very
hospitals,
good
the
point.
formularies won't even
Yep.
put multiple on,
Yep.
whoever gets them the first. And then finally, something we don't like to talk about, but is reality, is cost. It's not clear to me there's a substantial difference in cost,
There
although
might be a
There
difference in
might be.
copay.
There might
well,
be different copay,
copay
absolutely.
and
Yeah.
although if we go to routinely 200 niraparib, it actually is about 2/3 of the cost of the other ones. So that's
So let me kind of go through my scorecard here. So olaparib was the first one. We have long-term data. We have familiarity. We even have a breast indication in olaparib. Okay, and then you go. Well, Nova was the first one approved in maintenance. It really is the most formal data because as a non-BRCA and a BRCA randomized, you said it was once daily. Probably the best PARP trapper. It's lipophilic. It crosses the blood-brain barrier. And then the new kid on the block is rucaparib. It's kind of fun and sexy because it's the new guy. You talk about dose reductions. Rucaparib has lots of options, 6, 5, 4, 3. When you dose reduce niraparib, you go a third.
Third down.
So,
right.
so
well,
maybe
we know the exposure on that is probably sufficient.
maybe. So, and also maybe the toxicity issue for rucaparib is a little favorable, except because the transaminases are not really important. So when I talk about the 3 PARP inhibitors, I ask people to say, just tell me which of those things are important. And if once daily dosing is one really important, it's really easy. If, first to market, familiarity, long-term data, it's really easy. Or the dose options and so on.
Yeah, and,
So,
I think the other issue, and then, but sure, I think it is important to go through the toxicities with patients, but then you can already kind of
tell us about that.
superimpose
Supportive care.
Supportive care, but also understand which drug is not going to be appropriate for that patient.
Give me some examples.
So I think, for example, if a patient has significant hypertension, she's already hypertensive because you've given her Avastin. And so her blood pressure is 160 over 90, and it's hard to keep down.
Niraparib has some idiosyncratic
that's correct.
hypertension.
That's because of the interaction with the norepinephrine transporter. So that's right. So then you'd have to tell her. I actually don't think I'd give it to somebody who's baseline hypertensive, and even someone who is normotensive. I think they have to understand. You got to watch your blood pressure. It's, more often than not, you're going to be fine.
But it's not
but
common.
just-
You measure it at home.
Yeah.
If it goes up, you stop and recover.
Or a patient who's got brain metastases or some kind of central nervous system metastases.
So then it speaks for niraparib.
For niraparib, for olaparib, whereas rucaparib does not cross the blood-brain barrier sufficiently.
Right, interesting. Yeah. So unprecedented times. And I'm not here to tell our audience or even to argue for one PARP inhibitor over another. I'm not even here to argue PARP versus BEV.
Right.
But I'll fight you hard versus placebo.
Right.
Or
Yeah,
observation.
absolutely correct. I mean, I think though, there are situations where maybe the patient, can't. There are situations, unfortunately, where cost comes in and the patient is having a hard time paying for the PARP inhibitor. And BEV is just not appropriate. So I think there are going to be a few patients who slip through, but they are the minority.
And there's frequently an argument that I hear about, well, once they get finished with their chemo, they don't want to come back and see you or see the hospital. I find it the opposite, which is that once they finish, patients are highly motivated to take something. That's, because you've already told them, look, it's likely this tumor's going to come back. They want something to keep the tumor away.
Yeah.